Good day, Tim. Can you hear me?
We can hear you.
Are we ready to start?
Yes, we're ready to start. You can load your slides.
We are good to go.
Yes, I think we can just put presentation slide mode.
Good evening. Good evening. My name is Dr. Masokwane. I don't know if you do the introduction, so what do I do now? Or should I go straight to it?
No, I think you can introduce yourself since you've already started leadership.
I'm the acting director of health services. And I think I put this topic in a broad there. I deal with laws all the time. I deal with issues of compliance to laws. I deal with issues of complaints about non-adherence to laws. So I thought maybe I should present this topic as generic as it is. When I went through it, I realized that, but I can't even touch 1% of what the laws cover. But I'll do the best to really present to you the core issues in relation to what obligations we have as health professionals, particularly doctors and dentists in the context of the law. I qualified in the Republic of Ireland in 2000. I also hold in the same qualification of medicine and intercalated Bachelor of Medical Science and Pharmacology. I've done Masters of Public Health and Masters of Medical Law. I am also a fellow of the International Society of Quality in Healthcare. So, in one of my functions that I used to carry out was as an inspector of health facilities, where I'm an accredited QMS ISO 9001 auditor. So that's me. I'm currently the acting director of health services. So the presentation will, feel free to stop me at any time if you so wish. I'll just give a bit of context in view of public health. What does legislature entail? Why do we legislate? I'll give a brief list of Botswana health laws. I'll also attempt to discuss the provisions of the law and what they mean to us health workers. And I must put a disclaimer that I can't cover the whole breadth of the laws of that health workers have to work with. You know, that once a person is born, they are born in under the first person they see is a health worker, and the last person they see is also a health worker when they die. So you must understand the magnitude of the work you do. So I'll not attempt to cover the whole breadth and length. So just a bit of context. Why am I talking to you as registered health professionals, as doctors and dentists and professionals in your own right? Health human resource is a vital building block of health. If you know, this is the model that we all know at WHO, and health workforce is a major building block. And if we don't have a resilient health workforce, we are more likely to crumble. People have talked before about why countries that have had developed medical schools for ages and ages are still training more and sometimes even building more medical school, because health human resources it's a very vital ingredient in this health system menu that we are preparing. So I also want to come to this model. This model is the model of Center for Disease Control, and I want us to look at this cycle. It always gives a cycle where we have assurance, assessment, policy development. That's more or less all that health workers do. We assess and monitor population health. We investigate, diagnose, we communicate, as this will details. But you see, one of the things we do is we utilize legal and regulatory actions to fulfill our obligations as health workers. As a result, this will enable equitable access to services. And these are the building blocks taken per verbatim from this Center for Disease Control in the 10 essential services of public health model. So the laws, one of the functions of public health is to create, champion, and implement policies, plans, and laws that impact health, is to utilize legal and regulatory actions designed to improve and protect public health. So I would implore you to bear with me. I made this presentation as basic as possible. I know for some of you, this might sound as if the basic, particularly people who are dealing with public health. But you may actually not know what we need to let people know in this regard. So if this section of the presentation is a bit rudimentary, please bear with me. So, as I say, laws are used as a tool to realize positive health outcomes in countries. For example, health legislation can prohibit conduct that is injurious to health. The Tobacco Control Act of 2021 is an example. It can authorize programs and services to promote health of individuals. Public Health Act is a classic example where we have the maternal child health program, infectious disease programs, and that law actually articulates programs. You can regulate the production of resources for health. The Private Hospitals and Nursing Homes Act as an act that allows us to ration private hospitals, so to speak, and then social financing for healthcare, and then it also allows authorization for assessment of quality of healthcare. For example, the Health Professions Act. So there are myriad ways in which these things are realized. The food and drug legislation, environmental legislation, occupational health and safety legislation. Law is a necessary way in which we realize policy. And there's always been a question, which comes first, the policy or the law? A law is an element that realizes a policy initiative. And one of the way you make a policy work is by promulgating a law to enforce what you already envisaged to be. So these are the Botswana health laws that I just want to present to you. The Public Health Act, Medicine-Related Substance Act, both are of 2013. Botswana Professions Act, Nurses and Midwives Act of 95, Private Hospitals and Nursing Homes Act 1989, Illicit Drugs and Related Substance Act of 2018. This last act is the ministry that's responsible for its implementation is the Ministry of Defense, of course, in collaboration with the Ministry of Health. As you are aware, recently there was a documentation published in the Gazette that actually now prohibited these substances that the illicit drugs highlighted in the schedule. So I will pick specific areas which we need to look into to avoid hovering all over the acts, and I'll just pick very pertinent issues that we need to deal with as health workers. And other laws include the Public Service Act, Public Authorities Functions Act of 1984, Companies Act for us in the private sector, who also have to comply with the requirements of the Companies Act, the Botswana Unified Revenue Services Act about taxation, Data Protection Act. Now, what is important, and the reason why I'm highlighting this act is because more Botswana, if you administer one law, you should not let another person break another law that you say no, because that is not under our custody. In other words, in your private clinic, you need to make sure that you comply to the Data Protection Act, even though the Data Protection Act is domiciled in another ministry, because these are laws of Botswana. That's why they often highlight them by chapter so chapter 64, and they're all, it's all one book. The book is the laws of Botswana. So let's look at these laws one by one. And the Botswana Professions Act is one of the laws that we are quite familiar with. It's an act of 2001. And the act mandates the registration of persons who work in a profession listed in Schedule B. Schedule B is a schedule of health professionals. It criminalizes working as a health professional without registering. Also criminalizes the act of calling oneself or purporting to be a health professional when not registered. And I think this is what we often fail to realize, that if you work and you are not registered, you can be charged 5,000 to 100,000, or imprisonment. I think imprisonment is 5 years, or both. So it's quite a serious thing. And what is interesting is that the act made the offense not an administrative offense, but a criminal offense, meaning that if we have Dr. Masokwane as a registrar, he can actually be sent to the police and get charged, or even go to the case. One of the reasons why we are motivating for amendment of these sections, so that we can have these sections be administrative penalties, is that if this law can be implemented to the latter, every our end of renewal ends at around June. Every day, June, when the month end 30th June, we now go and say we have 200 people who haven't registered. Imagine how many lawsuits we are going to have, or how many cases we are going to have of people we need to prosecute. And imagine how it will clog the whole system. But this has been highlighted as an issue. The council is not responsive, because it's actually condoning, it's punishment to those who register, because we don't enforce penalties. And then the Botswana Professional Council, and according to Justice Walia in Karebe versus Attorney General, she said it is a statutory body created to procure the smooth running of the health professions. I need to, there's always a commotion as to, is the BHPC independent? It's totally independent. BHPC, although the authorities delegated, appointed working minister, it's an independent body. So, and then what are the overall objectives of the Act? To promote the highest standard and practices of healthcare in Botswana, and to serve as a safeguard in protecting the welfare and interest of the public. I think this is Section 4 of the Act. What I need to emphasize, Kamelau, you will find that you will almost exclusively find laws being laws that enforce public safety. It's very rare to see a law that has been promulgated without a safety conscience movato. And the other thing that the laws always procure is public interest, to say, is the public interest represented? If you are going to look at maybe the law on company registration, and actually, it also looks into the fact that companies would comply, and as a result, companies will be safe companies, the employees there, and the people that they serve will be safe. So you'll find there's a lot of primary objectives of regulatory laws will be promoting safety and safeguard of welfare and interest of the public of Botswana. So the Botswana Professions Act also provides for the authority of the director to issue private practice licenses. And operating a private practice without a license attracts a penalty of not less than 5,000 or imprisonment of 12 months or both. So the other thing is that this law also obligates that professionals must be insured against professional misconduct litigation. As you may be aware, in public service, the government often buffers that part and so to speak, caters for when people are sued, they're defended by the Attorney General, and so to speak, the government takes that role to defend the public service employees. And I think I'm told that it's often a pattern in most countries for NEALO to say to attract people into the public service. So they have already indicated that the council is independent, it carries delegated duties, it oversees regulatory and registration standards and policies to make sure that what we who we register, the qualifications, and that the education is up to standard. Now, what are we obligated to do? We should register and maintain continuous professional development. I think I'm here as an advocate of CPD because although the mechanisms to enforce or to ensure that that is complied with are not yet up to par as we would wish to have that happen. CPD must be obligatory, really. If you don't have CPD, you don't register. Most countries don't do that. So I think it won't be far off that they will be logged in the new health profession registration system, and then if you don't fulfill it, it's not you are not registered. Actually, the Nurses and Midwives Act, the Nurse and Midwife Council, ensures that CPD is complied with. They don't register somebody who has not fulfilled CPD. So Public Health Act 2013. Now, I always like to look at this section 3 because it's an important section. It says, any other legislation on public health shall be in addition to and not in derogation from this act in as far as it is consistent with this act, and in the event of any conflict between the legislation and this act shall prevail. So we often miss context and we think that maybe it means a public health act can have precedence in administration of medicines, for example. It is a public health function, and yet by and large, the issue in question is medicines. So it does not mean the Public Health Act takes prerogative over other sections of law of healthcare. It means in issues of public health. For example, it's an interesting dilemma because people have said the way the Public Health Act defines a child is not necessarily the same as the other definitions of who a child is. So in issues of public health, the child will be as defined by the public health if we are dealing with a public health issue, for example, contraception and things like that. So I just wanted to clarify that one. So now this is an exact cut and paste of what, and it's a way that will realize what the Public Health Act is. It details the functions of the ministry as being to promote public health, to promote personal health and environmental health, prevent and guard against introduction of disease, prevent or control communicable disease. So in essence, the way the functions are put in this act, it actually shows why this is an umbrella legislation, so to speak, that covers many functions that the ministry carries. And it's a very important act that you should read and know. Now, I need to highlight very key functions or key obligations to us as health workers. We are obligated to report notifiable diseases, Section 52. We are obligated to allow authorized officers access to our facilities. The Public Health Act has got two classes, health officers and authorized officers, who are, so to speak, they were called inspectors, who can have access into your facility if you know the health inspectorate. They function under the ambit of this act. They are given authority by this act to come to Princess Marina to see compliance, to come to your Dr. Masokwane's private practice and see if it complies to public health. And also, it also defines programs. You know, it talks about the maternal child health, non-communicable disease. So most programs are emanating from this act. Now, there is one obligation that most, and I really wanted to share this with you, that most of you are not aware of. If I go to Dr. Charles as the superintendent of Marina and I demand a record, Yami, if Dr. Charles doesn't give me that record, Dr. Charles as the superintendent can face a prison term. He's not able to the public is entitled to their records. And the hospital and the hospital leadership can be charged. There is a section, I think it's 145 you can, if you are not anybody, if it lays several conditions, one of them, if you are not able to provide that record, it's an offense. Now, and you also, we can contravene. Not having a permanent record is that Section 145 says a person or body in charge of health facility shall maintain a permanent health record of every health or health service or every user of health services at the establishment in the prescribed manner. Of course, it can be qualified with regulations. But I'm highlighting this because it's one of the issues there will be a lawsuit and then the records would be demanded to assist in the case. Sometimes the owner of the records want the records to go and sue and they are not giving it to them. This is a section and it does not only apply to this, to government only. It applies to private sector as well. Even know that somebody can demand this record from you in that clinic, because as far as the law, you are obligated to keep that permanent record and be able to issue it to somebody in that regard. I wanted to spend a bit of time here to clarify this, because it's one area whereby we don't seem to know that we are mandated by law to have those records accessible and available to their owners. And then the Public Health Act also mandates proper complaint management. It allows that the minister must have a complaint management in which health workers, health users can complain about the services that they did not get. Currently, we are trying to come up with a streamlined process that we deal with. If I can also share with the participants here, the ministry is going along the way of doing mediation as a way to deal with issues. We really want to deal with complaints in the way of mediation and mediate even when the private sector is involved. And remember, the ministry works two ways. When there's a complaint about Marina, the ministry is the provider. But The ministry also can hear a complaint about Dr. Charles Clinic because the ministry licensed Dr. Charles. So there is a regulator. So that those role, either way, complaints can reach the ministry as detailed in the Public Health Act. So the other act that I will touch is the Medicine and Related Substance Act, which is an act to provide for the registration, regulation of the sale, distribution, importation, exportation, manufacture and dispensing of medicines and related substances and matters incidental thereto. Now, you may find that the MRSA, I know when you are talking to clinician, MRSA is not a good word because you're thinking of that bug in the hospital. So it provides for storage, sales, and use of medicine. It clearly details pharmacy professions as dispensers and as leaders in medicine use. Doctors, veterinarians, and dentists as prescribers. And it provides for special powers to the minister to grant dispensing rights to other professions other than doctors, dentists, and veterinarians. Provides special powers to the Director of Health Services and Director of Veterinary Services to allow other health personnel to dispense. But so I'll try by all means not to be controversial here because, of course, I'm the Director of Health Services, and there were court cases involving this legislative interpretation of this, and to try and be professional about it is to present to you what the law details rather than to for the lack of a better way to go ronkgela lebadi le leng gore gongwe lotlhe re le health system we just recovering from it. So obligation of MRSA 2013, safe medicine, good prescribing and dispensing practices. But so now I encourage you to read these laws. Currently, we are not totally enforcing what these laws are saying. If you were prescribing a medicine and over medicine got trade name, ideally the pharmacist shouldn't honor it. The pharmacist should call you and say, no, you are contravening regulation 36. Here you should use generic and approved international non-proprietary name, or the real names of those drugs. I always go to the private clinics, public clinics, a specific brand. And the other thing is, I don't know if all of us know that we need to keep copies of our prescriptions correlated. Of course, in the public system, the copy is kept in the hard copy. Me, we don't keep it anywhere. I had a patient who came to my clinic, such and such a medicine. If the permanent hard copy record disappears, you can't defend yourself to say on such and such a date, I prescribed HCT instead of this other medication. So I wanted to highlight this. These are salient points where we really need to look into that clear in black and white. So now the Private Hospitals and Nursing Homes Act is another regulatory act that allows for licensing of larger private health facilities. These facilities are licensed by the signature of the minister, and according to this act, the facilities are divided in this categories: medical or surgical, medical, surgical, maternity hospital. But this is a very old law. I don't know how old we were in 1989, and but I think the person who promulgated this law was quite clever, in the sense that because he could not anticipate the level of requests for the facilities. Bullet 4 and 5, a home for the care of accommodation of convalescent or chronically ill persons, a hospital for the care of specified class. So bullet 5 clearly shows that anybody can apply for any type of tertiary facility or any type of secondary facility that is within a class of a hospital. This is where, as the office of the director, we then got leverage from this and tried to license a lot of facilities using this clause. So because it allows for you to say, Dr. Charles will come and write a proposal that he wants to open a facility, let's say a home away from home for psychiatric patients. It can still be licensed under this section because it allows you any, so to speak. So I think that's although I can announce that this law is been recommended for repeal for it shall be called the Health Quality Act, where it will allow us to license both public and private. I think it still has a bit of life in it. So now I'm going to conclude. And as I conclude, I want to share with you the bills that are before. So before that the ministry intends to do. We intend to amend the Nurse and Midwives Bill, Nurse and Midwives Act of 95. As I said, the Health Quality Bill of 2022 is an amendment of the Private Hospitals and Nursing Homes Act, the Health Research Bill, Health Professions Bill, both of 2017. Now, you may wonder, these bills, these bills were awaiting rationalization of parastatals. And it is hoped that an agreement will be reached because the challenge with having too many parastatals is cost. And if we are going to have multiple authorities at tremendous cost, it will become unsustainable. So the Food Control Bill, the Chemical Substance Related Products Bill, Medicine and Related Substance Amendment. So the aim of the new amendment of the medicine is really to try and make sure that the country comes to maturity level 3. And then Chemical Substance Related Products Bill, I think it aligns to the Cartagena Protocol, or one of the protocols that deals with safe chemical use. And I think amongst the things that are relevant to us would be to have a poisons registry and things like that. So I was just sharing this with you, but the still on the pot, are not yet ready. And now, in summary, if you look at the obligations of the doctors, that what we are obligated to do, Public Health Act mandates us to run programs, to report diseases, to comply when the time of emergencies come. Botswana Professions Act allows for registration and compliance to the Code of Conduct. The Nurse and Midwives Act is the same for nursing profession, and the Medicine and Related Substances Act calls us for prescribing, dispensing, and proper medicine use. Illicit Drugs and Related Substance Act of 2018, we need to know this prohibited medicine. I think then the interesting point is this. We will have our pethidines, morphines that are also implicated in this act. Although they are allowed under the Medicine and Related Substance as schedule, I think it's schedule 1, but they are not necessarily allowed under the illicit drugs. For nobody, you shouldn't expect to see somebody go re-tisitse in a pub a tshotse pethidine o ka se go tlhaloganye gore o etsa kae, because those are illicit drugs. Although they are also medicines, they are also illicit drugs. So Employment Act, so if you know our obligations to to doing pre-employment examinations, assessing patients to see if it's a requirement of law. A doctor must examine somebody. And the other thing that the Employment Act mandates is that only a medical practitioner can give a sick leave. The other thing that I also need to highlight is the Public Service Act. Section 29 of the Public Health Act indicates that where a person is not able to work and is assumed to be incapable to work because of a medical illness, the person will be subjected to a medical examination, which is called a medical board. So it is our duties as the doctors to assess these people objectively. And I can highlight to the team here that we are working on improving the forms and the documents to assess patients, because it's one area where the forms and the processes are quite old. What we often do is we write to facilities to request for the process is just too long. There's duplication of processes, and it's one item that has been identified by the digitalization project that it will be digitized so that we don't delay in helping these clients to get assessed to see if they are fit to work. And then, of course, the good doctor here recently talked to us about birth and deaths. Dr. Mugoma talked to us about registration of deaths recently. And on my concluding point, really, I would like us to know that there is one major issue that I haven't dealt with here of medical negligence litigation and what you are expected, because I know today is the third of the three-part series that we had organized. There is a major issue, but please know that when Dr. Charles sees a patient at accident and emergency, let us know that that is a legal contract. The mere fact of saying, can I examine your abdomen? That is a contract, and as any contract, there will come a time where the contract would demand for a Dr. Charles find delay in the abdomen, or the patient then complains that no, I don't think that's what Dr. Charles wrote that he found. That's not what Dr. Charles should have done. So medical negligence litigation is a real and a real present problem. It's not increasing in double digits percentages. It's increasing in more than double digits percentages. 5%. We are talking more than 50%, more than 100%. Total, I can confidently say, if you will recall negligence, Cabo 2011, compared to now, the cases have skyrocketed. So it's an area that I have not talked to, and it's an area where we need to take stock of ourselves as clinicians, because we often face a challenge where when we need to respond to our actions, we feel as if it's an extra work. Where somebody was attended to you 5 years ago in a certain clinic, and you don't think you owe that patient or you should write the reports and even be able to be a witness. And then, of course, there would be on another note, the expert part, where you would be called as Dr. Charles, and you say, between your ethical obligation and before this court, should such a treatment have been done, give us your experience. It's something that as a registered health professional, it's well within our mandate. So, I thank you.
Thank you so much, Dr. Masokwane, for that very concise but very important presentation. I think at this juncture, we'll open the floor to comments and questions. I do note there isn't any questions in the chat box, so maybe we'll allow people to just react or ask any questions they may have. Anyone is free to unmute their mic to ask that question. Thank you. I don't know. I don't know if it's an element of fear or what's going on, but I appreciate this presentations that are done on behalf of course the Union of Choice BDU. But I do note that we tend to realize that there's quite a lot of things that doctors are not aware of that can really land them into trouble. I see a comment that reads as follows. What about the A4 half paper as opposed to cards? I don't know if Dr. Lekang can just maybe verbalize his question, unless Dr. Masokwane can, unless Dr. Masokwane understands the question.
Hi, good evening, guys. Sorry for joining in late, actually. Maybe you might have touched on it. This thing of patients coming with OPD cards that are half, looks like something is torn in by a ruler in half and then it becomes an OPD card as a referral. Are those things, can they be used in court of law?
Thank you for that question, and it's a question I've been asked before, and particularly this question also boils to what: can I, as a patient, ke tsamaele ka dikarata tsa e go ithekela di notebook ke dire di records tsa me go kwala mo teng? I think the answer is yes. That document, as long as for the moment ke tsena ko A&E e bo ba stempe sa se kwala se re mafika ko tleliniki, that is a medical record ka gore ke tsentse dikano tsa I've put identifiers of Ministry of Health mo teng. So it will suffice as a record, particularly that what is a medical record? Medical record is a document whereby clinical care was documented, and I don't think le molao kwadile go pegela gore e tshwanetse gore in what form. I think if you saw that section 141, it said in a prescribed format. But tota hela, I think some of these things, it's maybe intricacies that show our deficiencies, because it's number one, durability ya gore re kwale ya OPD care mo di karateng that go with the client that we can't have access to. Next, this A4 half paper will come electron, and it will be being convinced for Dr. So and so took care of me, and this is what he wrote. And sometimes they are actually brought in court. So let's say, this is what you wrote in this A4 size. And to answer directly, as long as we say it's a medical record, because a medical record just documents care. But to say, is it the best practice for that way? I don't think we should be going that way. Facility, we should be able to say document the care in the electronic system as well as in the paper. But it's okay to dream, and I'm told the dream won't be far-fetched. This digitalization and one health record in ministry way about that. I hope it will work in more public service. I hope, and it's something of high priority. Or Dr. Lekang he's only writing in this paper that will disappear.
Great. Any more questions, comments, reactions? Okay. Okay. No. I think okay, there's another comment. Does the minister or director of public health have the powers to exempt a health practitioner for registration by BHPC? I don't know if you were able to appreciate that question, Dr. Masokwane.
Yes, it's a very pertinent question. Does the minister have the power? The direct answer is the minister doesn't have that power, because otherwise, what happens is, I think it's even international law. When you have seconded powers, a delegated authority, you only give motho yo go delegatileng, or what do you call it? You only give them appellate powers, or me doesn't mean when the minister will not direct the council. Let's say Dr. Masokwane ke re ke a go register, the council doesn't register me because they don't think I'm a doctor, as I say, and I appeal to the minister. The only thing that the minister can do is to request an explanation from the council. Why was this person not registered? And then an explanation would say, no, Dr. Masokwane does not qualify because according to ABC, his practice is deficient in 1, 2, 3. And then more often than not, if the minister thinks this person, as the minister, I'm not satisfied with the opinion of the council, the minister can write back to the council to view it otherwise. What the minister can do is to say, I've heard your line of thought in the decision, but have you thought of 1, 2, 3? At the end of it all, it would still be the council that decides to register that person. And I think the thing with the law is currently that it's, when you are not registered, the best thing is to approach the council again, comply with what they have not, what they are querying, or go to court. And people have gone to court and won, because the court is there for everybody. And then the other question here says, what do you say about referrals from doctors with a single line? I think this one I'll ask you, Baretu. It's a question. I'm another doctor and I write to you, a colleague, get a back pain. I think it's about, it's a question of my clinical etiquette. Or tota, am I doing right to refer to Dr. Lekan? What do I want Dr. Lekan to do? I think it's an issue of practice and an element that we should it says a lot about the doctor than actually what they were doing.
No, thank you for that explanation, leadership. I don't know if our 3 doctors have any reactions to what you said, if it was clear. Is there any more comments? I think we were wrapping up. It's 7 o'clock. Any burning comments, any questions? No, I think, okay, there's a question. Is the definition of brain death clear? Can we stop ventilation? That's a question for you, leadership.
Yeah, about 2014, I was involved in promulgating national organ transplant policy. And one of the clear documents, one of the clear message that came from the document was the Botswana has to put it in law for death key. We don't as yet have a definition because one of the issues are end of life issues. They are not articulated. The law that articulates them, public health, that should articulate them is the Public Health Act. And I have to agree with the learned doctor that in the laws of Botswana. I've been told, and I'm subject to correction here, that Moma had thing, when we know that this patient, other countries, this patient will more likely waste resources by trying to care for them, prolonging suffering. We are able to call the relatives. In fact, I do remember that in Ireland, we could call patients, relatives that at 6 p.m. or at whichever time the family chooses, we are going to cut the life support machine. And more we tend to let us labor because we haven't legislated it. I think the DNR have been practiced and I don't actually think there is a legislative support other than ethical. And I want us to understand that an ethical decision as opposed to a legal decision, which is why ethically, I'm definitely sure you still keep that practice whereby when you are having with extreme low birth weight and they are still having pulses, you still do too little. Anything more will potentially not be of interest to the client. And what I'm saying is, the Dr. Saleshando and Julius, they lie on the ethical side of things, which does not necessarily need an articulation in law. But I would tend to agree that in relation to brain death, we need to legislate it. Or tomorrow we have a situation where they say, Dr. Saleshando or Dr. Charles killed my mother. Mela, we currently don't have it.
Great. I think it's clear. There's quite a lot of work to be done, a lot of clarity that needs to be sought from the legal perspective. A lot of gray areas that we are working together to make clear so that we are all aligned. But other than that, I think the time is 7:04. Let me use this opportunity to immensely thank our acting Director of Health Services, Dr. Masokwane, for taking this time to present to us, as well as organizing all 3 sessions that we've had so far from the legal perspective in health, as well as, for being a very important partner in terms of everything legal in health. We appreciate it immensely, and we hope that we continue to work well. Otherwise, for the viewers or the participants tonight, I'd like to thank you also for being a part of this, for taking that initiative to educate yourself so you can be better and safer doctors. Let's continue to share with others the knowledge that we gain from these presentations, as well as just to encourage others to join whenever we have the CMEs. They're very important for us and the patients, as well as the nation as a whole. Let's continue to reconsider joining BDU for those who haven't joined BDU. I do note some people here who are not BDU members. Is one organization for you that houses all your needs. So you'll make the right decision one day. But otherwise, thank you, everyone, and good night from us all.
Thank you.